Dr. Catherine Hewison graduated from UWA and became a GP in Perth. She's worked in Perth, rural WA and Queensland, Aboriginal Health Services. She's also a key part of Médecins Sans Frontières Australia, the world's leading independent organisation for medical humanitarian aid. Her first MSF mission was in Afghanistan in 1999, followed by other missions in South Sudan, Kenya, Darfur and Georgia. Among her roles in Médecins Sans Frontières include interim in operations department, exploratory missions, data analysis studies, and being on the board of directors of MSF Australia. She is also a medical advisor on tuberculosis, specialising in drug-resistant TB, in the medical department in Paris headquarters since 2005. Please welcome Dr. Catherine Hewison.
So my name is Catherine Hewison, and I do work for Médecins Sans Frontières, but I work in the Paris office in the headquarters of the French section of Médecins Sans Frontières in the medical department. I first started working for MSF in 1997 in Afghanistan, and what I'd like to do today is just give you a little bit of an idea of what MSF is, what Médecins Sans Frontières or Doctors Without Borders is, a little bit about who works with MSF and what sort of people and what sort of professions work with MSF, and then just give you my personal experience, what experience got me into MSF and what experience I've had since I've been in MSF. I try not to talk too long, I mean you can just talk forever, so I'm trying not to talk too long because I think questions are more interesting because I think people always have questions about these sorts of things. So, just who is MSF? So Médecins Sans Frontières was formed in 1971 by a group of French doctors and journalists who were working in Biafra at the time of the big famine. Biafra was in Nigeria. Big famine, and they were mostly working for the International Committee of the Red Cross, and they were really frustrated by the fact that they couldn't speak out, they couldn't talk about what they said. If you work for the Red Cross, that's one of the limitations, that to be completely neutral, they don't say anything about what they say. So these journalists and these doctors formed MSF with one of the goals of MSF to be speaking out, talking for the people that receive the victims of violence, the marginalised people, the refugees, the displaced people, people without a voice, and that's really part of what we do. Neutrality is also part of what we do, but not in the same sense as the. So what do we stand for? So neutrality is in there. So we will treat anybody. We will treat usually both sides in terms of a conflict. We try to treat both parties so that we're seen as being neutral. Sometimes it's not possible. We go where the needs are. So we assess the needs ourselves and we decide ourselves where to go. So we're not told by a government, the international government or a local government where they think the needs are. And this is very, very important because often aid can be manipulated, often aid is used as a political tool, and the most people in need, the most marginalised people miss out on wars because they're usually the ones that are in need because they've been discriminated against or in the middle of a war or whatever, but it's for us it's really important that we see the needs with our own eyes. So for example, North Korea, we have been working in North Korea for a long time, 1998, because at the time of the famine, we were not allowed to assess the needs ourselves, and we were not allowed to distribute the food ourselves. So all the other aid or government agencies that were giving aid would just give that aid all to the government, who would then distribute it. Did they distribute it? Nobody knows. But probably when North Korea opens up in the next few years, maybe, we'll find that probably millions of people starve to death and never receive that aid. So for us, we would rather say no and walk away than to not know what's happening to the aid or not be able to make those decisions ourselves. And just walking away is a statement in itself. And sometimes that can have an impact. For example, in Ethiopia, the big famine band-aid, I think you all remember that one, probably don't at all remember that, but it was a big famine back in the 80s, and we were very much involved in distributing aid, and we came to understand that a lot of the aid was being used to forcibly displace people from their land and also pretty much they were getting it. So we made a decision to speak out about that, which ultimately led to us having to leave the country, but it was an important decision which made that situation become public, and there was a lot of debate around that. MSF, you might know, won the Nobel Peace Prize in 1999. Some people find that quite surprising. We're a medical organisation, so it's a bit surprising for the Peace Prize, but it was, I'll just read a little quote from the president who accepted the prize, and he said, "Science has long been confused with neutrality and has been presented as a necessary condition for humanitarian action. From its inception, MSF was created in opposition to this assumption. We are not sure that words can always save lives, but we know that silence can certainly kill." So that's a really important part of MSF. The third thing, so we've got the neutrality, or impartiality, if you like, is independence. So it's really important for us to be independent financially, and as I said before, independent in our actions. So we decide where we go, what we do. The financial independence is fantastic because it means that when there's an emergency, we don't have to wait to do a nice proposal to a government agency to get our money. The days go by, the weeks go by, we're there. 1 day later, 2 days later, we're there, we're in action, and it's fantastic. It's great to work, and I don't know that any other organisation has that luxury. I mean, we are a rich organisation, if you like, a rich non-governmental organisation, in that we have this ongoing donor support base that gives us that financial independence to act when we need to. It doesn't mean that we don't need money. We do need money always because we have big projects, ongoing projects like HLB projects, or in more zones where the war just won't stop, which are not very mediatic, which don't get a lot of money, and we need to keep on funding those to continue doing our job there. I mean, for an example, when the tsunami hit, we stopped taking funds after 4 days. Internationally, we had $100 million euros after 4 days, and we said stop. We don't want any money, more money specifically for the tsunami, because we know we cannot spend it there. And if we ask specifically for money for a certain project, we want to spend it there. But we wrote to every single person who given us money, and we said, do you mind if we use it in Congo, where we spend 10 million euros a year and nobody ever gives us any money for it, or in Darfur, where we did a big advertising campaign, we got $500,000, and it cost us $10 million. That's one section, so probably amongst the sections, $100 million per year. And I mean, for example, in Australia, I think only 2 people did not want us to use the money elsewhere. So just to say that financial independence is excellent. So, what do? So you could lump the things that we do into these sort of 4 categories. We mainly work in conflict areas, but that doesn't mean we're all the time on the front line treating war wounded. We certainly do that, but conflict areas are also refugees and displaced people due to conflict, or health, sort of loss of access to health care because of the conflict. So you've got Congo, Sudan, big areas, but there's also huge conflicts going around the world that we're involved in. Natural disasters, so Haiti or the tsunami, these sorts of big natural disasters will play a big role. In terms of medical aid agencies, there's none other as capable or as big as MSF, so we can do this. So in Haiti, for example, we're already present. Unfortunately, our structure collapsed, so a lot of our staff were in the building and passed away. But there were people who were still able to work, were able to set up immediately a triage system, immediately start. They were operating very quickly it was a surgery program we had in Haiti. So they were operating very quickly in a less than perfect situation, we said in Kent. And within, I think it was 4 days, we had We have inflatable operating theatres, so you inflate the tent in the operating theatre. It's air-conditioned, it's got everything, it's sterile, and we actually had an entire hospital, inflatable hospital with 9 inflatable tents going by the week. So, I mean, it's really, logistically, it was massive, and medically also, but it's our science that lets us do that, as well as our organisational structure that lets us do that. We have a big logistics base that it's in Bordeaux in France, it's right next to the airport in Bordeaux, and they send a full truck, which is a big aeroplane full of stuff, and just goes directly from the wherever it's needed. And we have a very good way, after 4 years experience now, we have kits. We know, how many bandages and dressings you need for 10,000 people. You know how many anaesthetic drugs you need for 1,000 operations. So we just ordering kits and it's out there, and actually they just come up and start working straight away. Health exclusion, almost 20%. So health exclusion could be anything from prisoners. It can be places where there's no health care at all. So one example would be Central African Republic, which is like just a border across the border. It's basically almost no health care. Parts of Sudan as well, almost Sudan. Or exclusion because of their race or ethnicity or gender. So Afghanistan, there are a lot of women. Or there's marginalised people like drug addicts or prostitutes. So that all comes under health exclusion. And then the other big one is epidemics and endemics. So we have epidemics like meningitis, measles, yellow fever, Ebola, that just pop up, emergency ones. You have your ongoing epidemics, HIV, TB, tuberculosis, drug-resistant tuberculosis. And then you have endemic diseases. We have also what we call neglected diseases, so sickness, Chagas disease, calorization and diseases. These diseases that are sort of forgotten by drug companies and forgotten by everybody else, but we still much better. So where do we work? So, mostly in Africa, lots of needs in Africa. It's not just because we like it anymore. Asia also, we work for 20 years in displaced people camps, people displaced from Burma and Thailand. We work in Burma. We're still working in Cambodia, tuberculosis. We work in Laos as well. Europe, we have in Caucasus and Russia, projects. And we also have projects in France, in Italy, in other places for illegal immigrants, basically in Europe, who sit through the net, a lot of access to healthcare. And in South America, a lot of projects for Chagas and other things like that are just another way of looking at it, 28% conflict, 39% we say stable, 30% internal instability, and which is most African, and most conflict. I mean, it's quite subjective how you classify these things. So we're quite busy. So I'm talking here about MSF International. MSF International is over 20 sections, 5 of them are operational. The operations are carried out from different parts of the globe. There's an office in Australia which is non-operational, but they send HR, they send finance, they do communications, and they do some operations, but just ad hoc. So 8 million consultations, 500,000 people in hospital, and lots of people vaccinated, lots of HIV people under ARVs, and quite a bit of this. So it looks like a lot to me, but actually it's tiny. It's just a drop in the ocean if you look at what the needs are in the world. But we can't be everywhere, and sometimes it's very hard for us to close missions because we know that when we leave, healthcare will go shook. And we do tend to feel responsible for that, but we have to make choices. We can't be everywhere, and it's sometimes not that easy to to decide. So, who works with MSF? So we have medical personnel, so doctors, nurses, pharmacists, physiotherapists, laboratory technicians, biologists. So for the doctors, we have lots of generalists, lots of people who have general experience in medicine. Then we have specialists and surgeons. If you come to do surgery with us, you've got to be a surgeon. You can't just practice with surgery. You've got to be a surgeon. We have anaesthetists, we have surgeons. And we have pediatricians, obstetricians, and other things like psychiatrists and things with nominations. But generalists are very, very popular, which you never know what you're going to do. So on the non-medical side, we have lots of logisticians. So what is a logistician? Logistician is the person that makes it impossible for medical people to work. So they get you the truck, they get you the drugs in the truck, they take the drugs in the truck to the person who wants to work. They make sure that they are good quality drugs. They make sure you have a place to sleep, something to eat, electricity, they make sure that you can live to do your job. And that includes making sure the hospital has got a roof, the hospital's got water, that there's beds for the patients, that there's heating if it's cold, there's a fridge for the vaccines, for the blood. So you cannot work without logisticians. And some projects are more logistic than others. So our vaccination campaign, there was one that just 5 million people. We were there were a lot of medical people, but the main job was logistics. You've got to keep 5 million vaccines cold. That's a major thing. You've got to get 5 million vaccines to where they're needed. And logisticians are really, 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 really important. And who's a logistician? Well, anyone who's quite clever at that sort of stuff. So you could be an architect. So that's really useful for us because we build buildings. Sometimes we always rehabilitate things. You could be a mechanic. We have to have a fleet of cars to get us around to our clinics, whatever. You could be the armament industry, So we like to see that you've got a skill, but you don't have to have all skills. You don't expect you to be all of the things. There's people locally that can get to do stuff for you, but you need to be flexible and clever at getting things done. Then we also have hospital stuff. That's logisticians. We also have admin people because you do have to pay people, obviously. We employ international staff. There's about 2,500 international staff that go over here with MSF, and about international staff, I think it's about 30,000, 29,000, 30,000 and 2,000. So a lot, 10 times as many local staff as there are international staff. So if you guys are international staff, you're usually supervising a team of local staff, and we're not all used to doing that. You might be a great GP, but you might not be a great team leader, and that's really, really important stuff. Team leading, working with a team, especially with a team who's not on the same place as you, probably doesn't speak the same language. So national staff are indispensable. There's no way. Darfur, I remember in 2004, I was medical coordinator. We had 4 projects. We were doing 1,000 consultations per week. They were not done by international staff. We had lots and lots and lots of doctors who came from culture and to do those because we just could not do them ourselves. Plus, we would just be slow in the route. So, just to talk about a little bit of my experience, how did I get there to work for MSF? So, the criteria to work for MSF. So, MSF wants you to be motivated. So you need to commit to 9 to 12 months going away. You need to have at least 2 years post-grad experience, whatever you do. And you need to be registered, kind of being struck off or something. Not have a recent gap either in your clinical experience, which might be hiding something, I guess. And experience in supervising and training others is pretty handy. As I said, the team player is without question probably the most important. and they really look for experience. So obviously you're not going to have experience working with another humanitarian organisation. MSF doesn't expect that, but they expect some life experience or work experience. Okay, so personally, how did I get in? So I went to medical school. During medical school, I did my this 3-month thing, the 25th and 6th year where you go somewhere else. Thank you, Dave. I did that in Zimbabwe in a rural hospital run by the Salvation Army, and the hospital was full of HIV patients without treatment at that time. And that was a really good experience. So that looked good already, that experience on my CV, on my MSF. Then in my intern year, I also did some rural time in Kalgoorlie. I did one rotation in Kalgoorlie. Then in the second year residency, I went to Cairns, Base Hospital Cairns, and I did some rural stuff there as well. And I would say that one of the most difficult experiences of my life was one of the locums that I did up there, and I've been in Afghanistan, Sudan, where you are. One of the most difficult places I've worked with them. And then I did a lot of locums in Aboriginal medical services, mainly in Kimberleys. So Water Creek, Victoria Crossing and Broome, and also in Wiluna, sort of central West Australia. So very good experience at working with people who are culturally different. So Wiluna, most people can speak English, so this way. Using different, other than verbal communication skills were really important in that medical sort of consultation. Being independent, you're the only doctor. You've got to do your thing. You've got great nurses helping you, but you have to make decisions and do stuff that you probably haven't ever done before, and you have to do it. You can always get support, which is the same in MSF. You can always get support, but you're on your own at the time with the person. And it also shows the motivation to work on those sort of courses. So that very, very good when I applied for MSF. Then I did some other things like I did some pediatrics. So this was also very good. I did 6 months pediatrics pretty much. I did the diploma in child health. And it was when I was there that I applied for MSF. And I wasn't really sure I had enough experience, so I was going 4 years out, 5 years out. And that experience, certainly the Aboriginal, working in Aboriginal medical services was, and having travelled, and also from South America, travelled, those two things were probably the most important, as well as having the pediatric experience was really, really, really key as well. So I was very much a generalist. I didn't have a generalist GP qualification, but I was very much a generalist. I worked at GP, so that's how I got there. So what did I do? So I went off to Afghanistan. I remember when I was waiting for the call to know whether I was going or not, and my sister said, well, as long as they don't send me somewhere like Afghanistan. Call came that night, Afghanistan. So I was stoked at that time because it was warlords fighting amongst themselves. It was very, very intensive. I only stayed 7 months, but I can tell you that after 7 months, I was physically and mentally coupled. You know, it was extremely tough, and it's a little bit like your first baby in your hospital base. Your first mission is nothing like hospital missions. It's an eye-opener. I mean, I try not to imagine what it would be like before I got there, but I still do imagine. And it was just mind-blowing. Afghanistan is magnificent. It is fantastic. People are lovely. At the same time, it's terrifying, it's scary, it's outrageous. You know, so all of those emotions in there were very, very close bonds with people that you're working with. You say their life more than once, you translate it, and then 7 months, you know, I just wanted to come home and go to the beach and have a beer and see my friends. And that's quite hard to reconcile in your head. We've been seeing these people in, you know, really in a situation, and it wasn't getting better. The Taliban had just come to north, it wasn't getting better, and it's not getting better. It's difficult when you're so invested. It's then difficult to cut it like that, come home, get on with your life. And I found it very difficult to get on with my life. I did though. It's not to be underestimated, that first mission and the support we need. So I was very lucky. I've got a very supportive family. My mum's very supportive, thank goodness, because I'm not sure all mothers that came to that because of Afghanistan during the war. And yeah, no, it was. So what did I do actually? I tried to improve the health services to the women, and so that involved working with the one female Afghan doctor who was allowed to go to the clinics with husband. And then there was quite a lot of fighting, so they went to go somewhere else and opened up a new clinic along the same lines. And then at the end there I actually did it, then there was more fighting and the Taliban were pushed out of the patient valley and I just did an export mission. And so getting around is not easy. It's, you know, we have to do basic apologise, they're not in a condition which might have arrived. You get stuck. The conditions are difficult. You know, if you've got a bad back, I wouldn't go. So this is a clinic. You know, it was a full-day drive to get there, and we would awesome, beautiful drive, and we would sleep there, do our clinic, and then stay for a couple of days and come back. One time, this woman trying to deliver a baby, she wanted to deliver, I could deliver it, put her in the car. Do the 6-8 hours and just pretty much together. So you know, she had all her layers on, you know, and she wasn't taking any of these layers off in Afghanistan. And as we went up to the drive, I was like, she just delivered at the door. So bumpy road is really helpful for our culture. So this, you know, I was a Martian, I was really a Martian. I mean, we were there, there were no other workers. One very close down. And female, I was the only female, I was only female medical person, so going out, they were doing straight statement. So if I went out, so at the beginning it was possible sometimes to go to the market, but after that having 50 people staring at me, walking up to me, it's quite intense, not that easy to deal with. Lots of poverty. Incredible. So this is one of our clinics that was in Chalet. So most of the buildings were destroyed. So we used containers to make our clinics, and it's really cold. So we tried to use this, but it wasn't very easy. But yeah, that's one of our clinics. So as I said, I did this exploit coming down the Panjshir, and it looks gorgeous, but what happened is the Taliban put up landmines everywhere, and all these fields were full of landmines. So what we saw as we came down the valley was every clinic had been converted into an amputation centre. And then the Taliban put mines on the doors of the houses and everything, because people had run as the Taliban came through, and then as the Taliban retreated, they mined everything, people came home and so we actually set up a project to help those languages. So then I actually did do some anaesthetics in the UK for 6 months because I was scared, you know, of all that intubation stuff and having emergencies. Then this is actually Sudan, so it's pretty later. But anyway, so I did a mission in Sudan where I was the medical coordinator. So medical coordinators coordinate several missions. They're responsible for the quality. So you kind of go to first mission to a doctor, then perhaps a field coordinator in charge of one project, and then medical coordinator in charge of several projects. Hopefully after a few experiences before. So we had to fly everything in. At Crim there was a lot of fighting, a lot of malnutrition, and then just sort of complete body health care. And so we put everything in aeroplanes and ensure that the strip was drying up, otherwise you would. The other mission we had in South Sudan this time was sleeping sickness. This is in Iba, the other still the south. And this was a great experience because it really, MSF has lots of like satellites. We have that logistic satellite, we have the epidemiological satellite, the SOMS, but we do a lot of studies and stuff. And we have the access for a campaign for access to essential medicines. So this was a good example. So when I got there, we were treating sleeping sickness with arsenic. And one or two patients who died from the treatment, and it was awful treatment. And there was actually a drug called DMPMO that was available, but the drug company making it and found to rework cancer, said they couldn't make it. Then we found out actually they were making it but selling it as a cosmetic product for $75 in the pharmacies. And so then we kind of had them in a difficult position. So then they donated 5 million treatments for sleeping sickness. And so we were able to change from arsenic to this treatment. Not so easy. The arsenic treatment last call was injectional status. This still is 4 infusions for 2 hours, which sounds easy, but there's dirt outside there. It's not very clean. There's nurses without much experience, and that's quite logistically difficult to do. So I just don't run out of time. So I just showed one. So this is our HIV mission in Homa Bay. So I went to Homa Bay in '99. So no ARVs yet. So when I got there, I think the first thing I did was go to the funeral of the surgeon who just died of HIV. Surgeon for like 1 million people. Then the director had tuberculosis and never tested himself for HIV, but treated with tuberculosis and died. 1, 2, or 3 nurses died per week from HIV. Nobody said the word HIV. Nobody said the word AIDS. Everybody died from a long illness. And the hospital was a 200-bed hospital with no running water, no waste management, and 200 beds of water people dying. The wall was so full that when the wind blows a certain direction, it was hurting, and she could not open the door. So we started with basics. We started with water, waste management, sharps disposal, set up a pharmacy because they didn't have any drugs, not ARVs yet, ARVs started in 2001. And counselling, testing, but you can do as much counselling testing as you want. People don't get tested unless they've got treatment. So it really took off when we started the treatment. But just to know that when we started, this is another campaign success story. This treatment was $10,000 per person per year when we started. So it's pretty, even within MSF, it was pretty hard to say, let's go for it. And now it's less than $200 per person per year. So that's a huge success story. And now there's over 20,000 patients in this project alone, and we've had lots of projects. And you see it's nothing here. What do I do now? So I work in headquarters. I'm a medical advisor, and I was previously a generalist medical advisor as well as specific, so I looked after Sudan. So anything that happened in Sudan, I would have to address whether it was malnutrition or malaria outbreak or whatever it was, displaced people. And now I also follow DOSIC, which was epidemic meningitis and tuberculosis. And now I only follow DOSIC, which is tuberculosis, a very specifically drug-resistant tuberculosis. I don't present myself as a specialist of drug-resistant tuberculosis. If somebody asks me what I do, I say I'm a GP. So I did, in amongst all of that, I did finish my GP training. I think it's very important to get your piece of paper. I've also got just finished a master's in public health epidemiology as well, but I'm not sure that was that. Well, I just did it now, so I'm sure it's not like